Now I'd like to introduce a physician who has deep experience with working with asthmatic patients. So I'm going to introduce Dr. David Keller. He's a professor of pediatrics at the Children's Hospital of Colorado and is also the immediate past president of the Academic Pediatric Association. Thank you, Dr. Keller.
Well, thank you. And boy, it's great to be here. It's interesting to speak up here without a podium, so I'm getting used to that. I'm a general pediatrician. I've been in primary care practice for 30 years, and I've worked in hospital clinics. I've worked at a community health center. I ran a small practice in a small town in central Massachusetts for a bunch of years, and I've taken care of a lot of kids for asthma. The challenge with dealing with asthma is the same. It has been the same for a long time. How do we provide great care to our children and families that has good outcomes at a reasonable cost? Really, we're talking about the triple aim that was articulated so well by Don Berwick and his colleagues a few years ago. It's been a challenge for many years, and most of us have thought that we could only do 2 out of those 3 things, that we could get good outcomes at good cost, but then we'd have to speed up our care so that we wouldn't be able to provide all of those things. I never quite bought that. I always thought we could do all 3 things. And so back, probably 20 years ago, I started going to learning collaboratives to learn how to take care of children with chronic diseases like asthma. I think my first one was in 1996. We've gotten better at it over the years, but we still have a long ways to go. Let me tell you what I mean. I'm going to start with a patient story, very similar to the one that we just heard, actually. The patient's someone I saw in my clinic the other day, and it really illustrates the points I want to make. Little girl, school age, let's call her Grace, came in for her annual physical. And I'd looked at her chart electronically before I walked into the room, and I noticed that she'd been to the emergency room twice over the last winter, both times for asthma. Both times had gotten treated with nebulizers, as you'd heard. And most recently had a follow-up in our office about 3 months ago with one of my colleagues who appropriately prescribed what we now call a controller medication, an inhaled corticosteroid, which is another way of delivering the steroids you heard about in the earlier story. So her chart said that she had mild persistent asthma. Our team gave her an asthma control questionnaire to fill out when she got there. She scored 20, which is okay control. It says that things are just in control. So I asked what I thought was a perfectly reasonable question. How is Grace doing with her asthma? And her mother looked at me and looked shocked because she said to me, no one had ever told her that Grace had asthma before. Her chart said that she had asthma. The family didn't say that she had asthma. And that perception gap is the problem. That's the core of the issue that we need to deal with. Because many of our parents, because the clinical presentation of asthma is such that for families, it can look like it's an intermittent illness rather than a chronic disease. And we like it when we like to think of our children as being healthy, so we don't like to think of them as having a chronic disease. And that leads us to a lot of complications. Now, we in medicine have tried to deal with that. We've come up with classification systems to try and understand asthma as either mild, moderate, or severe. We have different treatment regimens for different levels of asthma that we use. We work with families to understand this. And yet, if we do our job properly, the child should appear well. A child with well-controlled asthma should be able to run and play with every other child, unlike the story we just heard. He should be able to go to school and not miss school very often. He or she should be able to sleep well at night and not wake up coughing in the middle of the night. All of those things should happen if you take your controller medications. But when you're taking your controller medications, you appear to be a well child, and it can be hard for parents to remember to stay on them. To believe that they really need to be on them. So a lot of the work we have to do as primary care physicians is really educate people to understand the nature of asthma and what it is that we need to work through. The other problem with asthma is not an equal opportunity disease. It affects poor children more than it affects those who don't live in poverty. And there's a bunch of reasons for that. Most of them environmental. Environmental tobacco smoke, for example, is a big problem for kids with asthma. Early exposure to environmental tobacco smoke increases the rate of asthma by like 30% early on in life. It's a real problem, and getting people to quit smoking is really hard. We do that in our offices now, but I think it's a challenge for us. We have, add to that the problem of living in inadequate housing. If you have housing that has lots of dust or cockroaches or rats, notice the symbols all appearing behind me, or dust, something like 80 or 90% of children with asthma have allergies attached to that asthma, and that these things just stir it up. They trigger asthma attacks that result in frequent trips to the hospital and actually can result in requiring higher doses of corticosteroids with more side effects that go along with that. So that can be a problem. Finally, add to that just living in crowded conditions. When you live in crowded conditions, you get sick more often with viral illnesses. That triggers more asthma. And I'm looking at my time. And that triggers more asthma and can, especially with a virus called respiratory syncytial virus, which when contracted early in life really causes problems for children. So we have all of these environmental triggers that lead to poverty being a major factor in the distribution of asthma around our country. All of this results in costs. $27 billion a year were spent on pediatric asthma care. It's an annual direct cost of about $3,000 per child. Then you go add to that the cost of missing school. 14 million, we estimate, sick days per year of missed school days. And that doesn't even account for all the missed work days for the parents who have to stay home with their children when they're sick from school. This is a tremendous cost to our society, to our payers, and to the families, and needs to be addressed as we move forward with designing systems to try and deal with all of this. So what do we do about this? Well, the good news is we actually have the scientific evidence to know what to do. There have been evidence-based guidelines in existence since 1993. They've been regularly updated, telling us how best to manage asthma care. All children with asthma should have their asthma graded and their treatment designed appropriately around the severity of their disease. All families and children should work with their providers to have an asthma action plan to try and know what they should do to handle the asthma when it happens. They should use their inhalers properly and be trained in how to do that, and they should have regular visits with their pediatrician or their asthma or their care provider to address fine-tuning their asthma care. Next slide. And that is the challenge before us, because what you can see is that in caring for children with asthma, the problem isn't about the medicine and the science. The problem is designing a system of care that supports families in such a way that they get the right treatment for the right problem at the right time. It really is all about the triple aim.